This is my Veronica.
You don't own me? No, she didn't.
No. Well, this is my wife, Veronica. I went through life not really having feelings for anyone because I trained my brain to not like girls. Until I met Veronica, I couldn't help myself. It was like the easiest thing I've ever done. Like getting into a warm bed at the end of a hard day. It was just so natural. Just feeling really close to another human being. I've never felt that before, I guess. To this point, and just having a best friend around all the time. Everything is a little more fun when you have someone to share it with. I'm just trying to stuff the scared feelings down with this food. It's just chicken salad. Because, yeah, I don't know. I don't think it's hit me yet. I'm going to be jumping off of a cliff and just hoping that I don't die. Want some coffee? Okay. All right, let's go.
무서워? 아니, 아무 생각 없어.
Ta-da! Okay, over here. Let's check this side. Flipped in, locked, good to go. All right, I think we're ready.
When I was a child, I couldn't imagine having the life I have now. I am just growing every day. I am gaining courage. I'm realizing nothing in life is that scary. It's just the idea of something that's usually scary. And I'm happy now.
You ready?
Good evening, everyone. Good evening, and thank you so much for coming tonight. It is wonderful to see this room and to see this packed and to see how we've changed the angle of the room from our previous years, so it's really wonderful to welcome you. For those of you who don't know me, my name is David Scott. I'm the Executive Director and Director of Lifelong Learning here at Congregation Beth Israel, and it's a pleasure to welcome you to the Lyon-Cohen Symposium. This is our third annual Lyon-Cohen Symposium. We are actually excited for next year's fourth annual Lyon-Cohen Symposium, so you can put it on your calendar for next spring. The subject next year is going to be on media, ethics in the media, so it should be very timely and interesting, so don't miss next year. I want to go ahead and welcome Rabbi Lyon, of course Rabbi Scott, who is up here, Rabbi Herman, our clergy team from Congregation Beth Israel. We're here to welcome you as well. I also want to welcome the chair of Houston First, David Mintzberg, who is here. Thank you, David, for coming. Thank you. Kenny Friedman is here, chair of Houston Sports Authority. Thank you, Kenny, for being here as well. Thank you. I just want to say a special word of thanks to Marcy and Bob Zlotnick. Thank you, Marcy, for all that you do to make this program so successful every year. We couldn't do it without you. Thanks, of course, to Marcia Gilbert and the kitchen staff who does such an amazing job. Isn't this food great, guys? Really, well done. Thank you, Marcia. And to Patrick Colbert and Michael Reddick and your team, thank you for making everything look so wonderful and so beautiful. Also, a special word of thanks to Rabbi Carr for being here tonight as well. Thank you, Rabbi Carr, for joining us. Special thanks to the members of the MBJLC, the Miriam Browning Jewish Learning Center, Ashley Mills, Alyssa Weinstein, Gabby Burgard, and Jared Pickett for helping set up and coordinate and get everything ready for this evening's program. I also want to say thank you to Lee Snyder, who is over here with our sound, and Greg Tucker, who we can't see, who is actually running our video. This is the first time we've done this in this room, and we're live streaming right now over the internet too. So a real 21st century program here at the congregation. I'd like to, before she comes up, I just want to thank Mayor Pro Tem Ellen Cohen for being here as well. Thank you, Ellen. And thank you for sharing your husband's memory with us tonight. Looking around this room, it is such a wonderful legacy and a tribute to him. For those of you who have red folders, everybody should have a red folder with you. They have surveys in there, they have bios and other information about mental health. Please take these with you. If you don't have one, please come up and get one so we can make sure everybody has all the information that they need. As questions are going to be answered and passed out later on in the program, please feel free to write them down with the pencils that are on the tables. At this time, I'd like to invite Marcy to come up and also welcome you. Thank you, everybody, so much for coming. Have a wonderful evening.
Thank you. Well, welcome, everybody. I'm absolutely thrilled to present this program tonight. Thank you, David. I certainly want to echo your sentiments and thank the staff of the temple for their amazing work. They have gone above and beyond and even answered probably 99% of the zillion emails I sent them all hours of the day. So thank you so much to David and to his staff. I'd also like to recognize the Lyon-Cohen Symposium Committee. This group of wildly intelligent, efficient, effective individuals that I often refer to as the rock star committee has worked tirelessly to ensure that tonight's event is informative, is relevant, and goes off without a hitch. So would the following rock star members please stand? Warren Rich, Anita Gaylor. We can hold, well, why don't we do our applause when everybody stands up? Warren Rich, Anita Gaylor, Phyllis Cohn, David Scott, Bobby Lapin, Daniel Gerber, Jacob Leon, Lisa Stanton, David Hassett, and Dr. Ed Septimus. Thank you all so much. If we call a meeting for noon and it's 12:01, every single person of this committee is on the call and wondering why someone's late at 12:01. It is truly an amazing group to work with. Also, members of the committee will be walking around and picking up any questions that you have to ask the panel. So you'll see during the panel discussions, these same people will be walking around. And of course, to our panelists and our moderator, you know, you guys just didn't get to come up here and speak. No, you've participated on several calls, and I've really relied on you all to help vet the content. It just isn't something I'm familiar with, and you were unbelievably gracious and helpful. And of course, you also got a zillion of my emails, and thank you so much from the bottom of my heart. And to all of you who are here tonight, I know this isn't a fun topic. It's not sexy, but it is so relevant, and it affects every single one of us. Thank you, truly, for making the time to come here tonight. And lastly, if you'll indulge me for maybe 2 more minutes, I'd like to introduce my family. Someone who should be sitting over there is my grandmother, who unfortunately passed away in the last 2 months at 101 3/4. But I have no doubt that she is watching, and she and her sister are critiquing everything. They are discussing the food choices. They're discussing what everybody's wearing and whether my lipstick is the right shade or not. So we miss you, Grandma. Introduce my husband, Bob. I've got my eldest son, Kevin, and my daughter-in-law, Lauren. My second son, Mitchell, and his date, Molly Wickman. And hello somewhere to my third son, Matthew, who better be watching, along with my brother, Eric, sister-in-law, Jill, and nephew, Eli Cohen, my aunt, Mary Lou Cadis, and my mother, Ellen Cohen. My dad, Lyon-Cohen, was a mensch. And for those of you unfamiliar with that term, it's a Yiddish word, and it means a person of integrity and honor, someone to admire and emulate, someone of noble character. The term really isn't used that often because it's considered the highest compliment, expressing the rarity and the value of that individual's qualities. Yes, that was my father, Lyon-Cohen, a real mensch. And it's an honor to remember him with this annual symposium and scholarship. This year, I'd like to ask my mother to join me on stage in presenting the Lyon-Cohen Merit Scholarship. In its second year, the scholarship is given to an individual who exemplifies my father's optimism and devotion to ethics. Thank you.
Okay, all here. Thank you very much, Marcy. You said it just like we wrote it. I had nothing to do with it, nothing. I would now like to invite Kevin Kotamarti to join me up here, Kevin. And as he comes up, I'm going to tell you about him. Kevin is receiving the Lyon-Cohen Merit Scholarship Award. He is a resident in anesthesiology with Baylor College of Medicine. He's also a classical pianist, so he's a real Renaissance man. My husband took up the violin when he was about 56, but that's about the only similarity in that part. In his application, Kevin said he hopes to one day work with his brother, Aaron, who's here with him today, who will be attending medical school shortly. Ultimately, they want to work together to design tools used in operating rooms. Kevin, these tools in the hands of skilled surgeons who use them extended my husband's life from original diagnosis of 18 months with his cancer to 18 years. So you do everything you can to extend other people's lives as well. Kevin also said in his application that Judaism teaches us that we must always treat others with dignity and never take advantage of another person. something Lyon exemplified. I know he would be so proud that you are the recipient of his scholarship today. Congratulations.
Thank you. Yeah. I just wanted to thank everyone and their family for this opportunity to be here with all their friends and extended family, and this is such a big honor to be here. Thank you.
Thank you, Kevin. Thank you very much.
Thanks.
Thank you. I'll join you at the table. Yes. And now it's my pleasure to introduce Bill Kelly, whose bio is in your program, as are the bios of everyone on the platform. I would, however, like to tell you that Bill, well, let me put it this way. If you think that I have done a good job as a competent state elected official and as a city council member, then you have Bill to thank. If you think I have done a rather poor job, then you have Bill to blame. Because Bill was my first campaign manager, and he took a girl from a small town in Ohio and made her a state representative in the state of Texas. And I was extremely impressed with his intelligence and his ability to work with people. I now have the distinct pleasure of working with him again at City Hall. Ladies and gentlemen, my friend Bill Kelly.
I have a wealth of experience in being told what to do by Lyon-Cohen, and being here today is no exception. So thank you very much. My name is Bill Kelly. I'm the Director of Government Affairs for the City of Houston, and I cannot tell you how thankful I am to be in front of an audience and not talk about pensions. So thank you all very much for indulging me that opportunity. However, right now I really do have a distinct pleasure, and that's to introduce my friend Maureen Hackett to give us some opening remarks. It is not too much to say that Maureen has done more to move the conversation and affect real change when it comes to behavioral health issues in a state that is a very difficult environment to see that change made on both the medical, on the stigma, on all different sides. She has encountered a number of obstacles, and those obstacles I really feel sorry for because they are in the way of Maureen Hackett. So Maureen, come on up.
Thank you for that. Gosh, I feel like a bully. No. Thank you so much for being here. This is a remarkable size crowd. And for me and for several in this room, what a treat to be able to talk to you about a passion, about a human civic right that we all have, and to get your impressions and to get your questions answered and for you to champion this cause with us. Please join the journey. So at this time, let me give you some background information of things that we're going to talk about. And first of all, I will refer in these documents to what is currently in so many, the DSM, a psychiatric textbook, so many things, and it refers to mental health, mental illness, and behavioral health. My journey and my job, I promise you, is to change that to the science of the brain. We're talking about the brain. We're not talking about anything else. We all have one. We all came in with one, and we all deserve to have a very healthy one. So as you leave this room and people want to ask you where you've been, you can say you've been to a conference on brain health. That would be helpful. Thank you. So let me define, going back to the word I can't stand, mental illness. It's a major disturbance in an individual's thinking, their feelings, or the behavior that reflects a problem in mental function. Mental disorders cause distress, sometimes disability, in social, work, and family activities. That's in the DSM-5. This illness refers to all diagnosable mental disorders, health conditions that involve significant changes in thinking, in emotion, behavior, and mood, as well as distress and/or problems functioning socially. It affects them in work, in their family activities. So what is mental healthiness? Well, that involves effective functioning in daily activities. What do they result in? Well, productiveness at work, home, being a caregiver, healthy relationships, the ability to adapt to change and to cope with adversity. That's what mental healthiness is. What about ethics? Have we defined ethics? Ethics defined is the basic concepts and fundamental principles of decent human conduct. Pretty simple. It includes the study of universal values, such as the essential equality of all men and all women, human and natural rights, obedience to the law of the land, concern for the health and safety, and increasingly also for our natural environment. That's the definition of ethics. So tonight, our panel is going to talk about 3 different disorders, or I would say situations of mental health. One is OCD. What is OCD? That's obsessive compulsive disorder. It's a mental disorder in which people have unwanted and repeated thoughts, feelings, ideas, sensations, obsessions, and behaviors that drive them to do something over and over and over again, compulsions. What is ADD? ADD is attention deficit disorder. It's a disorder of attention, disorder in organization, and impulse control, appearing in childhood and often persisting to adulthood. There's a lot of adults in my life who have said to me, I'm so glad I knew about ADD. That's what my problem's been all along. And I'm in my 50s. So, you know, this is something that occurs many times in childhood, but don't surprise yourself. It affects adults. What about ADHD? Symptoms of ADHD include inattention, not being able to focus, hyperactivity, excessive movement that's not fitting for the setting, impulsivity, hasty acts that occur in the moment and without thinking. We've all had situations that they've referred to children with ADHD. Again, this affects adults. Suicide, horrible. Suicide is the act of deliberately killing oneself. The risk factors for suicide include mental disorders, such as depression, personality disorder, alcohol dependence, or schizophrenia. And some physical illnesses, such as neurological disorders, cancer, HIV. So now let me give you the statistics. You've had the definitions. These are state and national statistics, 2015. Nationally, 1 in 4 adults has a diagnosable behavioral health condition. 40% of adolescents have had a diagnosable condition. Children data is unavailable at this time, but it's pending, and we will likely see it on the Texas Gov. In Texas in 2015, 7,250,000 Texans had a diagnosable behavioral health need. 75% were mild or moderate. In Texas, 105,000 adolescent Texans had a conduct disorder. 185,000 of those adolescents self-injured in 2015. 500,000 adolescent Texans were diagnosed with anxiety disorders in 2015. The cost of untreated mental health needs, let's talk about that. In Texas, it reached $2.2 billion in 2016. 300,000 Texans with severe mental health needs received no care. 92% of Texans with the most complicated behavioral health needs didn't receive the care they needed to avoid repeated trips to the jails, to the emergency rooms, and the shelters. Emergency rooms visits for substance abuse cost the state $450 million annually. With all that in mind, it's time to start the conversation about ethics. Again, the basic concepts and fundamental principles of decent human conduct. Thank you so much.
All right. Thank you very much. Setting the stage for statistics, I think, helps with the first topic that we want to really delve into, and that is the stigma that comes when even trying to address the topic of behavioral health and, like you said, the misnomer on mental illness with it. Dr. Shaw, one of the things that I think you might be able to illuminate for us, people often refer to behavioral health problems as not real medical issues. As someone who works in the field, why don't you give us your take on exactly how that is stigmatized, not only the disease itself, but also those that work to trying to prevent and treat?
Sure. Not only that, a lot of times when you see people, they ask you what you do, you tell them you're a psychiatrist. Oh, you're not a real doctor. So even otherwise, they sometimes say that. And working in a hospital setting, you a lot of times see people, they're worried about chest pain, they're worried about other physical illnesses, but their worry or their concern about psychiatric illnesses or brain illnesses is much less than the other. So stigma continues to be there, it doesn't go away. If you go to a ER, studies show that if you have a mental health illness or psychiatric illness in your diagnostic chart, your symptoms of chest pain may be heard less than otherwise. What are we doing to address that? It's a huge issue, it's an ethical issue actually. So that still continues, and in spite of all the things we have done to talk about ethical challenges and this and that, that hasn't changed a whole lot. And it goes not only from people, but it is still in professionals, meaning physicians and others. So.
Now, Dr. Spike, I wanted to pick up on that stigma theme that we were talking about. A lot of times it goes, I love the line, not a real doctor, I'm a psychiatrist. So a lot of times people associate this with this disease with a failure of parents, or somehow someone's to blame for it. How would you interpret that?
One thing I'll say is, in terms of not a real doctor.
Thank you.
As a philosopher, I definitely get the not a real doctor response, and appropriately. I would say if I ever wrote a prescription for someone, I should probably be arrested. So I wanted to comment first on stigma. There has been so much stigma, and I think part of it is people's fear of patients that have these kinds of problems. And I think a lot of people have a gut reaction of being afraid and pulling away from them, and that makes for a difficulty for them to have a normal social life. And I think it can be very hard to overcome that and realize that these people need you to make a little more effort to be empathic towards them, and let them see that you recognize that they are a person just like you and they deserve respect. So I think a lot of ethics when it comes to stigma is about making extra effort and realizing that every person has a story and it's worth getting to know them and caring for them. So that's what I would say would be the ethical answer. I would also say, just to emphasize how great the stigma can be, when we teach in medical school about charting everything about your patient, the one place where we say there can be cases where it's acceptable not to put things in the chart are with psychiatric diagnoses. And even official ethics textbooks for medical students will say sometimes physicians think that they will have a second parallel chart that's more confidential, and that's only for psychiatric diagnoses. So that gives you an idea of how extreme the social stigma can be.
With that, moving from the medical field, Rabbi Scott, to spiritual needs, how do you see stigma creeping into how you are able to carry with not only your profession, but with congregants?
Absolutely. Well, the ethics topic is very important, and it's exactly what Maureen started with in terms of looking at the whole person. And when a stigma is sort of like saying I'm normal or I'm not normal. So we're taught in the book of Genesis, in the very beginning of Torah, we're all created b'tselem Elohim, and each of us are endowed with a divine spark. And that is a part of our genetic makeup. And some of us have expert needs in one area, and some of us may consider them challenges in other areas, but we really have to look at the entire person. So just like a complete medical history, as a rabbi and as a spiritual leader, I look at someone's entire past, and there are times that religion and a significant life cycle event can have a very strong impact on someone. and in a way that we may not have imagined before. So thankfully, today we're in the 21st century, where not every ceremony we do looks the same. Not every committee we lead looks the same. And when we have the full picture of our congregation, that's what makes it so rich and diverse. And so we are being led in many cases by the parents of our students, or by grandparents, or by students themselves, who might express an interest in doing something a little bit different than we've done in the past, but it doesn't make it any less meaningful or spiritual.
Maureen, I want to go to you with the next question, and it's one that we've discussed quite a bit before, and it's really the, I'd call it the ethics of access. When we look at a society and what we do, and I think to pick up on what Dr. Spike had mentioned with regards to how the medical profession has treated behavioral health for years and years, how do we as a society look at ourselves and reflect on the lack of access for behavioral health that has led to a number of those statistics that you discussed earlier?
Well, I think we look at it and we start out very sad, and then we end up very angry because so much of it could have been a different ending. And I think that, to your point on fear in regards to stigma, we are moving slowly but surely. Look at this room, first of all. We are moving away from stigma. And I think the reason for that is the curiosity of what is brain health? What is brain disease? So many times we're out, looking at folks that don't have any access to care. And when they hit the ER, again, they're labeled right away. Our hospitals do a great job with most of what they can, with the funding that they have. But I do think that it's going to take an army of citizens to stand up for one another and say, it's not cool to say or call someone a name because you don't have the facts. Now, it's great to be courageous and fight this war for access, for anti-stigma, for better policy. For better research training and pay for our psychiatrists, our residents, et cetera. But the only way to do that is to have the facts. And that's courageous. Then you can fight the fight. So that's what we hope to do here, give you these facts and hopefully encourage you to fight the fight for access. It's just not fair. It's if we took this on as a humankind war, like we did with, bus rides and all that kind of stuff, this would be a different story. So let's make some noise. It's time.
Going right into that fact-based policy that we should have in being able to treat this. Dr. Shaw, one thing I wanted to mention while we're still on stigma, the stigma of even being able to prescribe treatment when you've had to be able to fudge a diagnostic requirement just so you know that treatment would be covered. What does that say that we are in a position where you as a treating physician even have to fudge on what you're able to do as far as treating your patients go?
That's also important. And just a little bit on what Dr. Spike said. The fear people have that patients with brain illnesses, and I like that term, so I'll use that more often, patients with brain illnesses are aggressive, violent. Less than 5% of psychiatric patients do violence. Less than 5%, 2 to 3 to 4% of psychiatric patients are involved in violence. Others are not. So we should focus on the other part as opposed to the less than 5% part. The stigma, or what you talked about, the ethical challenge about prescription, is numerous. First is the biggest challenge. In some ways, as a psychiatrist, you have to market your medication to the patient. You have to sell it to the patient. The patients may not want to take it. The family may not want to take it. The drugs may have side effects. They may cause weight gain. They may cause sexual side effects. So that's one issue. The cost is a huge issue. Some of the new medications, long-acting injections, are $3,000, $4,000, $5,000. And even if you have good insurance, your insurance may cover 80% of the medicine, and if you have to take it every month or every other month, it's all complicated. So you in your own mind are having a fight. How do you convince? Because first you have to sell your own self to sell it further, and it continues to be a fight. But I think the only way I think we can resolve it is by involving the families, which sometimes we don't. But if you involve the family, involve their primary care physicians and the whole team, if you work as a team approach, yes, you can resolve that. Otherwise, if you only involve the patient, it will be very difficult.
I think being able to look at how stigma affects each one of these areas really does go to show the work on taking it force on, as Maureen said with it. And I think one of the biggest consequences will be our next topic that we shift into, and that's the failure if we succumb to that stigma and leading to suicide, and not being able to get the access of treatment that people really need. And with that, Dr. Spike, there are a lot of, when you talk about suicide, there are obviously a lot of boundaries that people can feel trapped within as far as just overall discussions with family members, with physicians, with those entrusted for medical treatment. How do you see those issues being able to play out just within, let's say, that doctor-patient relationship, where if a patient comes in with suicidal ideations, how does that physician, what should be their mind frame in going into being able to address a situation?
Okay. So I think part of my answer there is we have to train every physician to ask how every patient is feeling and if they're having any suicidal thoughts. What often happens, I think, is that's left to psychiatrists, and there's a terrible shortage of psychiatrists in all 50 states. But when you go to your family medicine doctor, they should ask you something about how you're feeling and how's your life going and what's new with you, and look for any kind of sign that things are not going well. And if a patient drops a hint, they need to follow up with a good question immediately and eventually get to a point where are you thinking about hurting yourself? Do you think about how you would do it? Do you have the means to do it? So there's standard questions that physicians are all supposed to be trained to ask in medical school. But I think a lot of times what happens is they go into specialties and they feel like that's someone else's job. So I would say first thing is I would suggest every physician ask about patients' mental health on every visit, and then not just physicians but other clinicians as well. So if everybody was asking patients, they would have, we would be much more aware earlier of when there are danger signs.
Rabbi, in looking at how this translates to family units that you would interact with, your perspective on suicide?
Absolutely. I think that we also work as a team, and so as much as individuals come to the rabbi, we also look to the community to help us. And thankfully today rabbis are very approachable. Not that we weren't in the past, but even more accessible. And with emailing, there's a certain ease of being able to approach an issue with a rabbi without having to come right out and say it, at least initially. And that contact that we make in being able to address an individual and then to speak with a family and then to call in resources, call in the therapists and the physicians in our congregation in a very confidential way helps us really work as a team. So just as a serious medical diagnosis where you have a variety of doctors, pain management, and the diagnosing physician, and then the specialist, the rabbis really, we want to be a part of that team, and we want to be a part of that unit that really allows an entire family to feel comfortable sharing some of the hardships that they may be enduring, and to help them not to be cured, but to help them feel comfortable in coming here and finding a place for themselves here, and acknowledging that they are counted in our community, just like our people have been counted for thousands of years.
In talking how we transition from the physician kind of aspect and training for our medical folks to the congregants, Maureen, I'd really like to ask you, your work with the mental health channel on being able to talk and suicide being one of the topics that comes up with that. How do you think that discussion for society writ large has impacted misnomers with it, or really tried to be able to bring a difficult topic that is not something that people would normally engage in conversation on, something that you can, much more effectively address just in a conversational level like you would anything else that is something at the medical forefront that people would really be concerned about?
I think, the reason that it's so powerful, the video that was actually the clip that was on, is it could have been a tragic ending. It's a fantastic story about a young woman whose mother did not love her. And so she had a terrible upbringing. She's an Asian American, and she's LGBT. And her mom couldn't understand that either. I mean, this woman was going to take her life, decided that she would put Post-its in a cookie jar and decide what she was going to do on her bucket list. She wanted to jump from a plane, blah, blah, blah. Through all of this, she eventually got some therapy, and she indeed did not jump. The beauty of the mental health channel is that, first of all, there's no commercials, and gosh, do we hate that. There's no commercials. These are real people telling real stories. This isn't a doctor talking about the effects of whatever on your brain. Yes, we have some of those. But I think that the more people talk about the diseases that they are dealing with, and perhaps open up other people's eyes and ears to this, the better off we're going to be. I think we've made some progress in that way, but we still have a lot of ways to go. But watch that video; it'll tear you apart. But at the end, it's a great story.
Dr. Shaw, I want to go to you and talk about how a physician confronts with suicidal ideation and the different ethical questions that you then are presented with about harm to the individual, harm to others with it. But I want to take a moment to just talk about this statistic because it's so prevalent with it within the United States. I don't want this to become a conversation that's about a separate topic, but it's important to know when you look at suicide in the United States, we have 33,000 gun deaths a year in the U.S. About 60% of those gun deaths are suicide. That never comes up in the conversation with regards to quote-unquote gun control on it, but it should come up in the conversation with regards to how can we make effective policy to deal with behavioral health issues. And Dr. Shaw, as somebody who is on the front line of this, there was a piece of legislation last session that I know that you were actively involved with that had an unfortunate outcome, but really dealt directly with the frontline circumstances of suicidal ideations that you're often presented with. Would you care to share a little bit about that?
Sure. So, as you mentioned, 33,000 deaths gun-related, 21,000 plus of those are suicide-related. So it's even more than 60%. And what Dr. Spikes was mentioning, a lot of time physicians, other than psychiatrists, and even some psychiatrists, don't talk about suicide because of the same reason that their worry is if they talk about suicide and the patient says, I am suicidal, what are they going to do? They don't have the resources. They can't refer the patient. The appointment may take forever. They don't know what to do. They will get anxious, perhaps more than the patient. So that is the reason they just think, oh, it's better not to ask, because if I ask, I would have to do something. So they're not trained in doing that. As you mentioned yourself, suicide is a huge issue. It's the second leading cause of death in people who are between the ages of 15 and 34. Second leading cause of death. We have one person dying from suicide every 12 minutes. Like you mentioned earlier, or Maureen mentioned, 1 in 4 in this group has brain illness, mental health illness, 1 in 4. So if there are 10 people on the table, you can just look at you can count the numbers and see, but 1 in 4. And a lot of psychiatric illnesses result in suicidal ideations and death. Luckily, only 1 person would die if 25 would have suicidal ideation. If you work in a mental hospital, if you work in a psychiatric hospital, if you work in a psychiatric emergency room, 80% of your patients come with suicidal ideations, 80%. Not everybody has a carryable plan, but 80% of them. And the problem in law for us is that in this state, as a psychiatrist, if I see a patient and I'm in my clinic and I want to commit this patient because the patient says, I'm hearing voice of God and the voice tells me I'm going to go home and I'm going to kill myself and kill my family. As a psychiatrist, I would like to commit this patient to a hospital to get treatment because I know this person needs help. But the law doesn't support that. The law does not support it because it says until the judge signs it, I cannot commit the patient, which could be 2 hours, 4 hours. And guess what? The patient may be gone in 10 minutes. And if the patient is gone, and God forbid something happens, I'm still liable. As opposed to that, our law enforcement agency can commit a patient for up to 48 hours. So there are numerous challenges we have in our law when it comes to that. And when you think about professionals, suicide is more common in women, but in terms of physicians, it's very common in physicians and most common in psychiatrists because their lifestyle is very, very hard. It's not that easy. It's common in dentists also, but it's very common in psychiatrists also. So we have to think about all those things and not only help our patients, but truly treat our own mental illness also, or our own sanity also. So it becomes sometimes very difficult and challenging.
And you have our efforts to make sure that that policy gets changed, because it's wrong and we should
Absolutely.
not. We should.
It almost got changed in 2015,
We will.
as you know.
Almost. Dr. Spike, the number of cases that we have occur in a variety of issues. Like Dr. Shah said, with 1 in 4, you're seeing a full spectrum across the board. Should we be taking every case where someone presents with suicidal ideation seriously? And how do those kind of differ along the perspectives of whether that's a physician or a family member when somebody brings it up? What's our responsibility? What's our real ethical challenge when confronted with the situation?
Well, one thing we can think about is prevention. And if psychiatrists or people in mental health fields have a higher suicide rate, I think we need to ask, why do some professions have higher suicide rate, and see what we can do to improve the quality of life for people in that profession. So there's a term that was first used in nursing research literature about why there's so much burnout and turnover of nursing staff. And the term that they created to describe it was moral distress. When you feel like you don't have enough time to do a good job, or you're being asked to do things that you don't think are the right thing to do, you can become very, not just dissatisfied with your job, but very unhappy and depressed. And I wonder, for a lot of medical professionals, they wanted to go into the field to help people, and it took them 10 or 20 years of education and hard work and straight A's and Mcats to get to that point. And then when they get there, if they feel like they are paper pushers, if they're psychiatrists and they had thought they would spend an hour with patients and they get 10 minutes with patients. So I think we can look at different groups that have higher suicide rates and ask, why are we stressing them out so much, and what can we do to make it less stressful? I thought it's interesting to think about the rabbi's role, because maybe that is the professional who can still spend an hour with a patient when the psychiatrist has been booked every 15 minutes for a 10-hour day and then has to do insurance paperwork afterwards. So at least I think part of the answer would be that. And then, as I said, the list of questions that you should always ask include, do you think about it? Do you have a plan, and do you have a method? And if someone is desperate and they are telling you that they have a plan and a method, then ethically, yes, you should do everything you can to intervene, including calling the police or trying to get them hospitalized immediately. The state law does vary from state to state. This is the 3rd state that I've lived in and taught medical ethics. And it sounds like maybe Texas does have some lawmaking to do, and luckily we have all the right people in the audience.
I'll come to her and then go to you on that, because that's a huge one. So, Rabbi, I wanted to pick up on exactly what he was saying. How does Judaism view suicide and the various aspects that go along with it?
Right. Well, we value every human life as sacred and want to do our best to help every person live a full and fulfilling life. And we really work hard to address challenges that our congregants bring to us. And as Dr. Spike said, we do make ourselves as available as possible. We do a lot of listening. We do our best to keep track and to follow up with individuals who have expressed some challenges in their life, and to encourage them to continue participating, and also to help them come up with a plan of where the synagogue can be for them, or what are the kinds of things they can do. And we're very fortunate here at Beth Israel to have a very strong and solidified clergy team and unit where we discuss a lot of these issues of our congregants confidentially. And all of us go through our rabbinical training and complete a unit of clinical pastoral education. So we're by no means experts, but we're very sympathetic listeners. We do our best to listen to the issues and to consult with individuals like Dr. Spike and many other physicians and therapists in our congregation to know when it is necessary to call in someone of a professional basis in this particular area. So we don't ostracize anyone. We do our best to meet the needs of people, and sometimes it's very, very immediate. And this is what our calling is, and this is where we find our days that are go in many different directions too. So it's in these moments that happen in midst of the larger moments and some of the other, the real nitty-gritty of what we do, that we feel called to action and want to do our best to serve our congregants.
And can I just add, listening is the most important thing. So, you know, if you feel like you listen but you don't have as much to say, listening is the most important thing to do, actually. And there aren't words for the expert to say that will magically change things. It's having the time to listen and show that you care that's most important.
One more thing on that. One more thing about that is that we talk about people who commit suicide. So about 43,000 people committed suicide in 2014. But about 250,000 people tried and were not able to do it. So why can't we focus on those who were saved? And by listening and by doing what we're talking about, we can save perhaps 250,000 a year. And that's very important. And talking about burnout, we are actually trying to develop an app, because this is the day of app, for burnout, for physician burnout, and we are kind of going pretty good with that. So that's a good thing.
And Maureen, you wanted to bring up a specific example of the family and communication that went along right with that. So
to your point, all of you, about having a conversation with the family, that's extremely important. And if someone presented suicidal thoughts, it is your duty to make sure that they are safe from themselves as well as harming others. One tragic incident with a young woman who went to her minister for some help but didn't get that help because the husband wouldn't support the help, is the tragic story of Andrea Yates and those 5 beautiful children. A very sick lady. And for the attorneys in the room, George Parnham fought terribly hard for her not to receive the death penalty. And how did she not get the death penalty? Reason of insanity. Put her at State Rusk Hospital, gives her the medication, the thoughts come back to her. She lives it every single day. If someone had just listened to her and let her have her medications and put your arms around her, I think that could have been preventable. So there are a lot of sad cases like this, but I also wanted to say I think that people forget the seriousness of postpartum depression, and that's what Andrea suffered with.
postpartum depression being a huge issue, there are a number of bills this legislative session that frankly have some good momentum to extend coverage, to allow for better training for medical providers to be able to spot signs and symptoms. So we will hopefully not forget those lessons that have been too painfully learned in circumstances where we did not provide that training or that access. So I want to move on to the last topic we have that Maureen brought up earlier on OCD and ADHD. And Dr. Shaw, why don't I start with you on it? Is this a real issue, or is this parents wanting children to be perfect and over-screening, or is this something that we should really talk about when we talk about the topic of brain health?
I think it's a little bit of all, what you said. We definitely have a lot of people who have ADHD, but you certainly can say that it's a little bit overdiagnosed than what you see. And the reason it's overdiagnosed is that a lot of times non-psychiatrists, when they diagnose ADHD, they don't do any psychological evaluation for those patients. What happens usually is that ADHD, per the definition of diagnosis, is the diagnosis which you have to see a child either hyperactive or inattentive, or the symptoms Maureen mentioned earlier, in 2 of the 3 settings, whether it is school or office or home. But what happens mostly these days, that the family will go to a pediatrician or a general physician or some doctor, and they will say, my child's grades are falling and they're having trouble in school. And without getting a lot of information, in some cases, they will be started on stimulants. Now, not all of them may have ADHD, not all of them may have a need for a medication. There could be some behavioral changes which could be done, there could be some parenting which could be done, But the disease itself exists, so a lot of people do have ADHD and they need to be treated. 1/3 of the ADHD continues in adulthood, 1/3 of the people don't, and 1/3 adapt to living with it, so they may not need the medication. So it could continue in adulthood also. It is usually a diagnosis of childhood, but you're right that it's overdiagnosed because of the fact that we don't use the tools available to diagnose this disease.
So I have an ethical question for you, Dr. Spike. I know you're surprised to hear that. What if a school says a child won't be allowed back unless they're medicated?
Oh, I was afraid you were going to ask that. There was a case in New York State when I used to live and teach in New York State where a school said exactly that. And not only that, they went to court and tried to have a court declare that the mother was neglectful because she refused to give her child drugs for hyperactivity or ADHD. That was an incredible case, and that was probably when I first became very interested in this topic. And I think there are definitely some children who benefit greatly from medication, but I also think in ethics, the greatest focus probably in the past 20 years has been the importance of the rights of patients to decide whether they need treatment and what treatment they prefer to have. And so I feel like that was going way too far to try to impose treatment on the child. And I also think in that case, it's very important to talk to the child. So I think my view is that you need to have parents supportive of it and you need to have the child supportive of it, and you should not let schools do it. And you sort of are, by asking that question, you are raising something that has been the subject of a lot of discussion, which is the number of kids diagnosed with ADHD has skyrocketed, probably doubled from 30 or 40 years ago. And there's a lot of very interesting ethical discussion about whether there is an epidemic or whether we are overdiagnosing. And I would say, at least sociologically, it's very intriguing to consider whether over-testing and No Child Left Behind and pressures in the school, the amount of homework that's assigned, everybody wants to be in one of the top schools in the country, parents want their kids to get all A's, and we've maybe taken a lot of the fun out of childhood, and that could be why we have to medicate children, and that ethically is very problematic.
Rabbi, go ahead. I was just going to say, not only you're in a unique circumstance to where the focus isn't so much on school, where you're being able to see families when they're not taking standardized tests or having that pressure on there. How does that relate on your perspective?
I think the impact of all of this, though, does come here because we see it in inability to participate in religious programming and activities, and feeling as though a child can have an excused absence to attend a high holy day service because for fear that they'll miss too much and get behind. And writing letters to school and standing firm on our Jewish values of coming together and worshiping as a community is such an important value that we want to promote and we want to help ensue, and it's a part of our obligation to help the ongoing tradition continue. And if we look out and don't see any young people in our services or programs because they're worried about missing school, we've really done something wrong. You look at how much society has changed and how our synagogue has changed and how we alter times of things and we bring live streaming in and we do all of these creative aspects. And you look at schools today and they're more or less the same as they've been for 50 or 60 years. The hours are the same and the vacations are roughly the same and the amount of homework has gone up, not down. And at a certain level, to see young elementary students sort of struggling through homework and not having an opportunity to play and be outside and go and support causes for inner city children, that's where the learning is taking place. And that's where we want to see the families come in, and that's how we help to children to find their passion and their joy. And we have no qualms. We approach our students all the same. Some may excel a little bit more in school, some maybe find it a little bit more difficult, but we don't check any report cards. We're not looking at any grade point averages. We look at investing in them, in our Torah and our traditions, and helping them feel proud of their Jewish heritage and identities.
So, even the idea that every kid should have an hour outside during the school day to enjoy fresh air and to see nature and to relax and to play, that doesn't exist in a lot of schools today. And even the kids who you think, well, you know, my child's athletic. Well, how is it being pushed as something to add on your resume to get into a competitive college? And so you have to be on the team rather than something that's an enjoyable pastime. There are definitely studies showing just being outside and among nature is good for your mental health. So I think these are important topics. I also would add a personal anecdote in terms of the importance of listening to patients. Patients are not just adults, they're also children. And so there is a whole field of psychiatry, pediatric psychiatry, very important. They are trained to recognize that they don't just listen to the parents, they have to talk to the child as well. And I've taught that for years, and people would always say, yeah, but how old are your children? So I'm kind of happy to say I have 3 teenagers, and I haven't felt any need to change my opinion that you still need to listen to teenagers. They have more knowledge of how they feel and what they're going through than anyone else.
Maureen, going back to the question of access and how it might play with ADHD on there, are we creating different levels of haves and have-nots with certain folks able to access either needed or frankly overdiagnosed medications, and then some just without access at all?
I think we are. We're very guilty of that, and I think that, you know, who's going to take on the insurance companies, first of all, and get that whole thing taken care of. I'm also a big believer in a model of scales. Some people can afford this, some people can afford that. Let me tell you, they're all VIPs. Everybody in God's eyes, everybody's VIP, and they are deserving of this type of treatment. But the insurance companies are making it tough, the federal government's making it tough, the state government's making it tough. At some point in time, it's going to happen to some major player in the political world, and we're going to listen. And it shouldn't be that way. It shouldn't be Hollywood, and it shouldn't be somebody in the political world. You're all important, every single one of you, and you should be valued, and your children should be valued, your grandchildren. So yes, we've got to figure this out. I don't know how we're going to do it, but noise.
One of the best people at making noise this session has been our good friend Representative Ford Price out of Amarillo, carrying House Bill 10, which is one of the biggest progress that we would have in this state with regards to coverage and parity with regards to behavioral health coverage. And not only would it fasten it in state law, but would allow an ombudsman to work with the Texas Department of Insurance to making insurance companies have those in-network capabilities so that people can access that treatment, that they're able to not only get the physician diagnostic for it, but to get the follow-up treatment and making sure that they're in-network and have access with the insurance they're already paying for. So that bill has already been voted out of the House, and that's in the Senate. So definitely make sure that your senator hears from you to talk about House Bill 10. That's the easy one to remember, House Bill 10. So we'll talk about pension bills you can talk about later, but House Bill 10 for this one.
That'll send you to a therapist.
They're very quickly. Yeah. A lot of those legislators need to go outside.
Yeah, they do. They need to smell the roses.
Dr. Shaw, real quick on OCD. Yes. I wanted to make sure Maureen mentioned that at our kickoff to be able to talk about some of the cases that you see as I'm not sure if folks necessarily can relate well, as that one, that disease kind of doesn't open itself up to as much kind of commonplace experience as we've seen both in society, media, or whatnot. But tell us a little bit about OCD as you've seen it.
OCD is one of the hardest diseases to treat, not only because it's not easy to sometimes diagnose, but patients don't come forward. And sometimes they have shame, they have guilt, and a lot of times they actually even like what they're doing. So there are two kinds of OCD. One is a group which is liking what they're doing, meaning they're kind of egocentric, and the other is which is not liking what they're doing. And if you like what you do, and even if it's wrong, you can imagine the treatment is not going to be easy for that. The medical treatment available for OCD is not as good, although the techniques which are being worked on, like deep brain stimulation and others, which we have some experts sitting here, are really some remarkable treatments if done right. And those would be the way to go with OCD, because it is not a disease which you can easily treat with medication. People take medications, people go for therapy for years, and still they are suffering from that. And the other issue with OCD is that it causes tremendous anxiety. So you have anxiety, you have shame, you have guilt, causing depression. So you are in a bunch of diseases with that. That is the reason, really and truly, you need a radical treatment for that, which could be the surgical treatment, if that is needed for some patients.
Dr. Spike, are we at risk of over-labeling with regards to a number of these diseases? How does just that label that we put on with ADHD, with OCD, really kind of play into how people react to others that are suffering from brain health?
There was...
I'm sure. I listen to Maureen, I'll tell you that. Right?
There was a book titled something like The Last Healthy Person a few years ago, implying that if you read the paper enough, you will see yourself in at least one article and start to diagnose yourself and convince everybody has some illness, some brain illness. It was funny, but there's something to it. The only thing I can say about that is maybe if we think that we have an illness as well, we'll be more empathic to other people. So it might not be all bad. Just like cancer was once something that people were afraid to talk about and afraid to tell people they had. And then the stigma went away as people became more public. So maybe it's not so bad if we all think that we have some disease or other, and then we're more willing to communicate with someone else who we think has some disease or other. But I think for OCD, maybe another question ethically is how much do we treat them if they don't want to be treated? So involuntary treatment, not just hospitalization, but maybe making people take their medications that they don't want to take. So there's always ethical issues there. And I think sometimes psychiatric ethics gets criticized for having supported deinstitutionalization back in the 70s. The feeling at the time was there were too many people hospitalized, and some of them were didn't know they were going in for the rest of their life, but were never let out. And there was a kind of a civil rights movement to empty all the state mental hospitals, but often thousands and thousands of people were released in a very short time without any kind of follow-up plan. So I think part of the whole question that maybe we're dealing with is when is somebody sick enough that they need to be hospitalized? And also a phrase used in ethics a lot in psychiatry is least restrictive alternative. So if there's any way to treat people without either putting them in a hospital or restraining them, that's always preferable.
Absolutely. Rabbi, did you have any?
I think that it's important for us in the congregation to be aware of how people might need to fill a space or where they might need to sit, and to encourage them to have a conversation with us. And it's only after sometimes I've known individuals for years that we build up a good sense of trust, and they're able to share that they've either been through some treatment or had suicidal thoughts, and that it's building up a relationship in a safe place, in a comfortable place, and acknowledging that when there are people who may come to services who might look a little bit different than some others, or may do something, and having the space that can include them and not ostracize them. And so we've done a lot in the congregation with our inclusion committee and in conjunction with Jewish Family Service to help acknowledge that these are real issues facing our community, and ones that are not going away, but ones that we are learning through and helping to understand where we can be even more sensitive and more comforting.
Just to add a little bit, when I was in training, I remember they used to say that never take the diagnostic tool at home, meaning don't start diagnosing your friends and families. Because if you do that, you will find a lot of people having a lot of different illnesses, and that would be a problem. And the other thing about OCD, I would like to say, is that a little bit of obsession is not bad. If you have a little bit of obsession, like for example, I may have an obsession, which I do, that I would respond to my emails rather very quickly. That's okay. Or if you clean your desk, you don't leave work for tomorrow. A little bit of that is definitely okay. It becomes a problem when it starts interfering in your functional life, in your day-to-day life. That's when it becomes a problem. So we don't need to make everything as a diagnosis. Some of them are normal things too.
I want to pick up on one last point that went with both Dr. Spike and Rabbi Scott on it. When we, as a society in the 1970s, moved on that deinstitutionalization, what has happened as an occurrence is that we have really, and you look, everybody always says, quite frankly, that the Harris County Jail is the largest treater of patients with mental illness in the state of Texas. Not only is that true, there are more people on psychotropic medication in the Harris County Jail, and if you're in the jail, guess what? It's in-person treatment, than the entire capacity of our state hospital system of 11 different campuses across the state. More people receiving psychotropic medication in the Harris County Jail there. So I think that that's a perspective and an ethical issue when we talk about that societal access, and something that we need to think about. This isn't something that is in any way a localized problem. We have defaulted in many situations to allowing our correctional facility to serve as our safety net for psychological problems, and it is not what it should be, and we will change. Okay, questions from the audience here. Let me go with this, and this, I think, Dr. Shaw, you may be the first one on this one. Is mental illness defined that would not affect pre-existing conditions for insurance? You want to talk about essential health benefits and what we've seen since both ACA and Parity?
Right. So in the past, what was the case is that if you have a diagnosis of bipolar disorder, or even depression for that matter, schizophrenia or any psychiatric disorder, and if you try to apply for insurance, either you would not get insurance, or if you get insurance, your premium would be extremely high, like in few thousands. So with ACA, Affordable Care Act, that changed, and the change was that they could not deny insurance to anybody with any pre-existing condition. And I think the biggest beneficiary in that was mental health diagnoses or psychiatric illnesses. So that changed, and even if the ACA changes to something else, that perhaps will continue to be a benefit that may not change. So that is a good victory for mental health illnesses, definitely.
That House Bill 10 is crucial to making sure that those essential health benefits for behavioral health are enshrined in state law. Question for Dr. Spike. How was the case in New York schools decided?
Luckily, they decided they could not force treatment, and the child was not taken away. But the fact that it was in the courts was just stunning to me. In terms of insurance coverage, I just would add another important thing to access is the cost of the insurance, as Dr. Shah said. So there's something called community rating, and that's another important part of the Affordable Care Act, was you can't charge more from one person than another because of that pre-existing condition. So community rating is a term to always look for anytime someone is discussing any kind of change in the insurance laws.
Maureen, you have converted a few people. It says, the question is for Dr. Shaw and Dr. Spike. Are primary care questions to patients asking about brain health likely to produce answers that are accurate and useful, or are there too many false positives or false negatives?
That's a good question. The most common thing used by primary care doctors is to screen depression, and the scale they use is Patient Health Questionnaire 2 or Patient Health Questionnaire 9. Those are all self-reported, and certainly self-reported scales sometimes do have a little bit of false positive. But I guess the question to me, contrary, is, would you rather have a little bit of more false positive as opposed to just not diagnose? I would perhaps rather have a little bit of false positive. So that's okay, we understand that we have false positive, and that is the reason. That's a screening tool. It doesn't mean that you're going to necessarily not do anything after that. So it's a good screening tool, but yes, you will have false positive.
And I would say it may not be 100%, but I agree. As a surprising number of patients will tell you they're in trouble and they want help if you ask them, but they might not say anything if you don't ask them.
Maureen, I have a question for you as one of the leading advocates for reform in the state. Can pharmaceutical companies play a role if brain health issues, and by the way, everyone using brain health, this is how effective she is, I'm telling you. Issues are so prevalent, one would think that this is a potential market. Couldn't they bring pressure to bear on our legislators?
Oof, that's a tough one. That is, in my personal opinion, one of the most screwed up industries that we have. It's so competitive. It's all about the dollars in many cases. I think if we brought the pharmaceutical companies together along with these outstanding young entrepreneurs who are finding devices and new medications in one room and said, okay, let's just do one thing. Let's not concentrate on the money. Let's all concentrate on the mission. Wouldn't that be different? Let's talk about brain health for everyone. Yes, they can play a huge role, but it's so competitive. I think it needs to be done in groups, and that's a great thought. That's my next battle.
I've got one for Rabbi Scott, kind of a follow-up. Many parents don't give their children medication on the weekend. What's a Sunday school to do? Can you demand a child take medication as a condition? I think you've answered that pretty thoroughly, but just wanted to let you respond to that, as that's a real question for folks that are in our audience.
It is a question, and it's something we also face at sleepover camp in the summer, a big issue then. And so we do ask parents to, of course, disclose any medication or any special considerations for their children. But part of coming here to our religious school programming is also that it's very different, and the approach is very different. And we try to make it as experiential, and we try to make it as tactile and hands-on, and really make it the focus a bit different. And it's about coming again in community and in fellowship and in joy around our traditions. And so we have recess breaks, and we do a lot of movement, because that's an important part of how we learn about our faith and our religion. And it's not meant to simply read and be in a classroom where these students have an overabundance of that during the week. And so I think we cannot insist that parents do or don't do certain things. Sometimes we'd like to, but I think that we also look to, again, teaching the entire child and to finding a ways of bringing religion to them in a meaningful way. And that looks different for every individual. And we try to make it as enjoyable and as meaningful as we can for each student.
Dr. Shaw, what new medications are out there that have been effective in treating mental health issues or brain health issues?
Thank you. Maureen is really powerful here. There are quite a few new medications available, but if you think about what has changed the field, especially for the most common illness like depression, I have to think about ketamine. Because the standard antidepressants usually have a response rate of 40, 42, 45%. ECT, which is electroconvulsive shock treatment, usually has a response rate of close to 75, 80%, so almost twice. So if you think about antidepressants, 40, 45% people would respond, the others would not. And ECT, obviously, you all know there is stigma and people don't want to get it. It's a procedure, you lose your memory a little bit and so forth. Ketamine is an anesthetic agent, which, to me at least, and a lot of us feel like that, is a breakthrough in that sense, that not only the response rate is over 70%, it works very quickly, because antidepressants usually take 4 to 6 weeks to work. And imagine you are a psychiatrist, you see a patient, and you tell them, you're depressed today, so I'm giving you medicine which is going to take 6 weeks to work. Usually we hide that part, we don't tell that part usually. We just try to blend in that part. But really, it's serious. So if we have a medicine like ketamine, and right now we are actually doing research at my hospital on intranasal ketamine, and that would be great if you can have an easy availability of that. And A, the success rate would be higher, 70% or so. B, you get response quickly, so that would be a breakthrough. Other than that, in terms of psychosis and others, there's not a whole lot of breakthrough medicine right now. But for depression, that is the breakthrough. And depression is really important because 20 plus million people in the country have known depression. So it is very important in that sense.
Got a couple of great questions for Rabbi and Dr. Spike here. When entering a new family unit, one that doesn't want to address or talk about or treat mental health, brain health, what are the ethical implications of pushing them to address it and or staying silent?
I'm not sure who brought the family to someone's attention, but I think one thing I would say is in the hospital setting at least, there will often be a lot of conflict between family members. The stress of somebody being very ill brings out sometimes the worst in a family, and if there are two possible opinions, then you'll be sure that someone will latch on to each of the two, and so you have to deal with the conflict between them. One thing I would do as an ethics consultant in the hospital, when I sense that is going on, which is pretty often, I insist on talking to each person privately and separately. So in ethics, sometimes people want to have a family meeting, and that can be very helpful so that each person sees what the other one is thinking, but sometimes somebody's afraid to talk or has things that they don't want to admit in front of others, so you have to be willing to talk one-on-one as well.
Well, we don't have any families who have conflicts here in the synagogue. They're always shalom bayit. They're always very, very happy and thrilled. Interestingly enough, most of my experience is with individuals who will come to me pretty directly. And they'll say, Rabbi, I'd like to talk to you about something. And it's only after spending some time together that sort of other phases of the difficulty kind of unfold. And so I usually have a chance to start with an individual, and sometimes it leads to meetings with other members of the family who are kind of going through the same struggle, or oftentimes it's just about forging the relationship with that one individual. Mm-hmm. And after doing some active listening and making some suggestions by encouraging them to come to services or participate in some programs, I wouldn't say they've been cured, but they feel an outlet for themselves. And once they have that, often they are better able to handle some of the challenges that are going on, because the synagogue is really a haven and a sanctuary in its best sense that really enables people to get the sense of distracting themselves often from some of the other problems that they're facing, and give them a good outlet, a good healthy spiritual practice that begins here and often can continue at home too.
Maureen, this next one, I think it goes to a little bit, I would use a different word than they use in this on it, but our society inadvertently tends to stigmatize mentally ill because it tends to deny, and they put the existence of evil, but I would say violence. They associate violence with someone who is, quote unquote, mentally ill. One of the things that, when I was with Mental Health America of Greater Houston, to be able to talk about these statistics, because oftentimes the only time that you talk about brain health, behavioral health in the news is when you've had a horrible situation, and people tend to directly associate brain illness with a violent act. When in fact, when you look at the statistics, a person who is suffering from schizophrenia is 11 to 12 times more likely to be a victim of a violent crime than they are to commit one. Maureen, when you talk about that association that people put very unfairly with regards to both violence and behavioral health problems.
I think, first of all, we have our media to thank for that. It's sensational. I don't know how many of you watch the 5 o'clock news, but I can't do that anymore. I don't even think I can watch the 6 o'clock news, to tell you the truth. But I think that
Marcy's getting on that next year,
yeah,
right?
yeah, good. I think that it's a terribly unfair, untrue picture that the press shows us. Now, if you are a eyewitness to a violent crime, I think you're going to feel a little bit differently about this. Anger can come on, within a second. You don't know why that anger came there. It's a whack. It's a 3 or 4 popped circuit breakers in a 200 amp panel. Something had to have happened to make that happen. So I'm going to go with anger, and very violent anger. I think we need to straighten it out as to what caused it, what's the root of that. It's very similar to addictions. Why did they choose that when something else is deeply going on? Why did they choose the addiction for the Band-Aid? Violence is similar. This is how they're expressing. Something else is going on. So if we could get the media to champion turning this around, I think we're close. We can. We can change people's minds. But it's unfair.
Rabbi, how do you deal with ethical issues of confidentiality when someone wants to keep their issue confidential, but you recognize they need medical psychiatric intervention?
Well, we have an obligation to share any confidential conversations if we feel that there is some real danger. We do have professionals that we can consult, and that's when I'm fortunate to work in tandem with Dr. Spike and many of our other physicians. So there's a sense of breaking confidentiality. We also have to remember that our highest responsibility is to save lives and to help people encourage to choose life in a meaningful way. And when they're in need, we want to find them the help that they need to do it in a very sensitive and nothing in the most appropriate way. So we generally speaking, we're most of the time, at least my personal experience is that by the time I've gotten a call, most individuals are already in treatment or have recognized that they also do need medical help as well.
Can't get it quite close enough. Sorry. Everyone is also trained who deals with people who might need help to say confidentiality is extremely important, and I want you to feel safe telling me what's on your mind, and I would not violate confidentiality unless it was necessary to help you save your life or some other very urgent, very important thing. But it's couched in a way that you tell people you would violate it if it was necessary to save their life or someone else's life. So you don't give the impression that you would keep anything confidential, but you put it in a way that encourages them to feel like they can trust you.
Often what can happen is once someone has shared a very confidential issue, often at the end of our conversation, that individual will say, do you know, I think I would feel better if someone in the medical community would know, could you help direct me to someone who might be able to help? So having that first conversation often results in some very productive work in terms of building the person back up or helping them find their way.
This one's for Dr. Shaw, but I think Maureen, we want to jump in as well. A recent article reported an association between increasing suicide rate and the decline in the number of psych beds. The U.S. has fewer psych beds per population compared to many European countries. Okay, in the state of Texas, we wish we were like, Florida just about. We really are behind on our number of beds, so don't even look at Europe yet. There are only 22 beds per 100,000 in the U.S. How does Harris County compare? Do we need more beds?
You go.
Just talk and it'll start. Just talk and it'll start.
So Harris County, like you mentioned, it's 22 beds per 100,000. Harris County has less than 10 beds per 100,000. That's one. And if you think about adjacent counties or states, Texas has less than 10 overall. North Carolina, which is smaller than Texas, has 35 beds per 100,000. And you will be surprised that Mississippi has more beds than all of the other states, which is surprising. And not only that is surprising, if you think about public funded beds, because that's the most important, that's how you measure. In Harris County, we have only, let me just actually get a guess from people. How many beds you all think we have for kids less than 18, public funded, in Harris County? And Harris County includes part of Katy, almost till Sugar Land, Humble, Baytown, almost till Pearland. How many beds we have? 100, 200, how many beds we have for kids less than 18? We have 20 beds total for people less than 18 in this county. And if you think about kids, you divide them in less than 11. If your age is less than 11, you have only 4 beds for those kids. And length of stay is more for pediatric patients than for adults. So they are there longer, which means the discharge would be even more difficult. So what happens to those kids? And Maureen has seen that with me. She almost had tears in her eyes that day. She came for half hour, she spent maybe 2 hours. Yeah, and since then she hasn't talked to me. No, but truly, it was heartbreaking for her also, that these patients would be at a hospital like Bentop on a stretcher for up to 5, 6, 7 days waiting for a bed. And you think kids have insurance? They don't. Why? Because we have a lot of undocumented kids also. So that is a huge problem. So don't even get me started on that, because it's a never-ending thing.
Now that's just Houston, Harris County. Now if you go to Brownsville, very sad situation. You go to the Valley, it's worse than it is here. I've personally experienced this with a child who was in crisis, 16 years old. There was no place to go in Houston, no place to go. She feared for her life on a few of the floors, you know. But Bentop, these kids are laying on gurneys, on stretchers with adults who are in there for all different types of things. Maybe a gunshot wound, maybe a, appendicitis. It's deplorable. It is deplorable. It is not something. Right, and Texas Children's, same thing. Now, the other thing, they don't have any beds, and the other thing is, how long is the wait to go get assessed at all of these places for kids? It's up to 6 months to get your child assessed as to what they need. So we have a lot of work to do, but the biggest work that we do, I think, is to inform all of you, to inform people that you work with, you pray with, you live with, you play sports with. That's the best thing we can do. Yes?
And you're working on the legal aspect of it, or the legislative aspect of it. There is a move to increase the number of beds, as you know. But the move is to increase the number of adult beds more for competency restoration, forensic beds. In all those requests, there is no request for pediatric beds. So even with the increase of 150 beds or 50 beds or whatever ends up happening, there is not a single pediatric bed which is going to increase, which is extremely sad. An even more ethical challenge, at least to me.
I think one of the things that we can hope for legislatively, and we are pushing on it, and I know Maureen was pushing on it today, an expansion of our Harris County Psychiatric Center. And one of the things that you mentioned earlier is the scale down of treatment, because right now we have such a cyclical patient population because of the lack of step-down services. So you will receive some excellent treatment and get stabilized while you're inpatient, and that step down to outpatient care is not intense enough to be able to help support you successfully, and you then end up right back in a crisis stage where you're inpatient treatment. The percent that Harris County Psychiatric Center here, which is a 276-bed facility, has on repetitive cyclical patients, I mean, you really look at, if you were just able to determine and create a good system for those folks to have the step-down care that they need, you would increase your capacity just by making sure the folks that you have that are repetitive customers that come in are able to have that step-down care. I mean, it really is a capacity question, but I really hope that the shock that you hear about the number of beds available for those under 18 in Harris County spurs you to action to be able to say this is not acceptable in Harris County in Houston, Texas. We really want to take action on it. Speaking of taking action here, would you contact the family against patient's orders? How do you decide this ethical issue? So I guess this is both for Dr. Shaw and Dr. Spike.
I think it depends on what's going on. What we usually do in the emergency room, if the patient came on a commitment, and they are a danger to self or others, they are already on a commitment, yes, we certainly can contact the family. If the patient came voluntarily, then the picture changes. And if they are not a danger to self or others, picture changes. Texas is a non-TERS state, meaning if somebody threatens to hurt somebody, we're not obligated by law to let that person know, although in most situations we let the law enforcement agencies know, but not necessarily the person. So.
And I will always teach about the Tarasov case because it's important for everyone in psychiatry to know about it, and then let them know that states have reacted to it differently. So the Tarasov case happened in California where a student at UC Berkeley was going to a therapist and said that he planned to murder a woman who was a fellow student because she was refusing his expressions of interest or advances. Eventually he murdered her, and it became a lawsuit around the question of how far should a professional go to warn somebody if they know that their life is at risk. And the courts in California said the mental health professionals needed to do more. They actually informed the Berkeley University Police Force, but they didn't inform the city police and they didn't inform the young woman. Most states do follow the Tarasov rule. Even though it was only a case in California, it was kind of viewed as important case law for psychiatry in almost every state, except a few states that intentionally excluded themselves, passed laws saying that we don't want Tarasov to be the law here. But Texas is one of those states, so I think it's important to know that.
Well, I know we've gone through a number of questions. I want to make sure and give our panelists the opportunity to express some closing thoughts about our program, and if there's anything that you would want to emphasize for the audience to be able to take away. Rabbi, could we start with you and we'll go down?
Absolutely. I would say that the synagogue is a partner in all of these efforts, and we want to know what families are going through on a personal level. We want to support the efforts on the state level, and we want to make sure that we are being very mindful of how we can embrace and include every member of the congregation in the 21st century. And that I'm here, I know the rest of the clergy team, Rabbi Lyon, Rabbi Herman, are also here, and we're very committed to raising awareness for brain health and brain awareness.
And I think my last words would be, I've been very interested in interprofessional teamwork and the strength that you can get from having many people working together. So if there are not enough psychiatrists, and we will not have enough psychiatrists for a long time, then we need the help from all kinds of other professionals, including social workers and psychologists and rabbis, and I would also say teachers. I always remember the Virginia Tech shooter, and the person who alerted the police, unfortunately they didn't intervene and stop him, but the person who realized something was wrong was his English teacher, because he wrote these violent fantasies for his writing assignments in class. So I would just say, as a community, everybody can help by being sensitive to other people, and if you think someone needs help, telling them that you would like to help them, or that they, giving them ideas for places that they can go to get help.
I would like to say the most important thing for me, what I feel in our field of brain health, is access. And not only access, but early access at appropriate time and affordable access. Because what we are facing right now is that we have so many illnesses, which are brain illnesses, mental health illnesses, psychiatric illnesses, and there is no access. You want to see a psychiatrist, the waiting time would be 3 months. You need a child psychiatrist, the wait time is 4 months. If you are in public sector, you go for, in some agencies, eligibility, 6 months, 7 months. Now, if you have chest pain, would you like to wait for 6 months? No. So access is number one, and good access, and we talk about beds, but if we have access, if we start giving access, affordable access, early access, maybe we don't even need that many beds. Maybe we can treat things, because when I work in the ER, I see same people coming back again and again and again. Why? Because they come to the ER, they get medication, but they are unable to follow in the outpatient. They don't have appointments, they don't have money to follow up, they don't have money to buy the medications, so it's an access issue. Because we have over 20 million people with depression, over 4 million people with bipolar, over 8 million people with ADHD. We have people with mental illnesses, with psychiatric illnesses. We have 45, 44, 43,000 people dying every year with suicide. Every 12 minutes, one person dies with suicide. And like I said, we have 250,000 people who try to attempt suicide and don't die. What are we doing for them? And one thing which we didn't cover today, because it is itself a huge topic, substance use. Substance use is such a big topic that 80%, 70% of our population, which we see, have substance use. And what are we doing for that? We would rather give 1 cent to build a new Astrodome, but we would not give 1 cent to build a huge mental health, brain health institute. So this is something to think about, that we don't do a whole lot for this field, and we call it brain. Brain is the first thing. If you don't think right, God help all of us. So thank you.
I think a dream would be a collaborative effort on the part of government, our state governments, our media, our pharmaceutical companies, our teachers, our parents, our faith community, to come together, first of all, and define the science of the brain, and for people to understand, to take to the public. I didn't raise my hand and ask to be suicidal. I didn't raise my hand and ask to be schizophrenic. Again, it is physiologically based, and we should understand that. Therefore, we will move away from fear, I believe, of these individuals, of the whole field, and closer to what all the faith communities are trying to get us to do, which is to love one another, respect one another. I hope that we can get to that. That's a huge movement, but let's be the first to do it, and let's start with Texas.
I'd like to grab my City of Houston hat for my closing thought on it. Being a representative of Mayor Turner, I think as our advocates would well testify to, Mayor Turner has been one of the biggest advocates for increased access. He has a family story, growing up, one of 9 children, having a brother who had severe mental issues, and being able to try and find access for care as an uninsured family in Houston. It is tough. One of the things that Mayor Turner committed to during his campaign and as mayor, we have the only mental health division for a police department in the state of Texas at the City of Houston. We choose not to treat those who have fallen through the cracks as criminals when they simply have not been able to have access to treatment. We will fully fund that department. We're looking at actually expanding it. Frankly, it saves money if you look at it holistically, and it is the right thing to do to make sure that people get the treatment they need, not the incarceration that cost us all. And that's something that I think he would be very proud to state, and something that we continue as part of my job to be able to help advocate on behalf of the City of Houston for increased behavioral health resources at the state level. So hope I have done well representing the mayor's views with that. So with that,
let's give all of our panelists a round of applause. Thank you all so much. We do have some gifts to present, and I just want to say thank you to everybody for coming. You have surveys in your folders. You're welcome to please give them to any of the committee members at your tables or around the room, or place them into the box near the coffee machines at the main table. We also want to encourage you, if you met someone that you got to know tonight or want to see them again, come back Sunday night. It's a little more of a higher and a happier topic, as we're going to welcome a bunch of cantors singing Broadway music Sunday night. So you're all welcome to join us. And May is Mental Health Awareness Month, so it's a really perfect time to conclude our evening. Thank you all so very much for coming.